Dr. Nilesh, you are speaking on the mute, so we cannot hear you. We can just see movements.
Right, sir. Am I audible now?
Absolutely loud and clear.
Yes.
Right, sir. Welcome everyone to the latest edition of Practo Connect webinar. This is the 26th edition. And today being the World Patient Safety Day, our topic today is patient safety in surgeries, specifically in surgeries. So to talk on this topic, we have a panel of very eminent experts who will give their views on what they think about patient safety. And to take this forward, I would like to invite Dr. Abhijit Paul, the medical director at Practo Surgeries, a very experienced medical administrator and an anesthetist and an ICU intensivist who's been handling Practo Surgeries and showing us the way on how we can build a safe, quality surgical institute across India, various institutes across India for Practo. Dr. Paul, sir, over to you.
Oh, thank you, Dr. Nilesh. I feel a little jittery, when you say all this administrator and medical director, because for the last 35 years we have been known in our scrub suits. Dr. Shyam knows us better in that way, and those who have worked with us, they know us better in that way. So it feels a little claustrophobic when you say medical director and when you are in a tie and suit to do administration. But yeah, that is my current kind of position. There is a lot of noise coming in. Yeah, but more than that, I think everyone else could mute the mic. Yeah. So the thing is, I'm in a kind of role to kind of build up the surgical vertical for the Practo Surgeries, which is currently dealing with mostly secondary care surgeries and a bit into tertiary care, since we have just opened up ailments like joint replacements and in orthopedics and some complex plastic surgeries also. Going further, we also have our minds up in cardiac surgery and cardiology, which is what is going on. So general surgery is very much in, urology is very much in, plastic surgery is very much in, obstetrics and gynecology is very much in, laryngology, ENT is very much on the cards, dentistry is very much on the cards. And so, in fact, going forward, we are even envisaging to have our own hospitals across India. So that is the future that we see. But what we understood is during COVID, a large portion of the care came into a very hybridized model, where a lot of distant consultation on teleconsultations came into the forefront, where we had to really rely on technology rather than just being on the bedside and running around in the hospital, because of both our safety as well as the patient safety overall. So we'll try to focus mainly in today's discussion the nuances and the journey through COVID and post-COVID, mainly how we had to kind of hybridize our care, and since the COVID is almost coming off, I think the World Health Organization is going to declare end of pandemic very soon. That's what I hear in a very informal kind of a platform. But yeah, so we are slowly returning back to a normal or a paranormal kind of situation, what we are going to have. But then again, talking of safety, it was all about safety. And today, since it's been a World Safety Day, I think I won't waste time. I would rather give the podium to Dr. Abel, whom I'll just introduce him. He is our additional director for quality and patient safety, and also our clinical operations. He really contributes a lot into that. And Dr. Abel also was the joint director of NABH, and he was also the group head of quality and accreditation for Narayana Health Pan India. And also he was a very important person who used to take care of the safety aspects in HCG across India. And he's been a part of NABH and has brought in many hospitals to the to accreditation, and both as an assessor and as well as an assessee. And also he has deep insights into the JCI, since he has done multiple practicums with the JCI, and also that he has taken several hospitals to the Joint Commission International. So that's Dr. Abel. Along with us, we have panelists like Dr. Anand, who's the medical superintendent and the head of surgery at Kannur Medical College, Anjar Kandi in Kannur. We have Dr. Shyam, my old colleague. We are good friends, and we have worked on both sides of the OT screen, being a cardiac anesthetist, and he's one of the top cardiac surgeons in Kerala and in South India, who has got a wide range of cardiac surgery spectrum. He does almost the entire range, and he has built up hospitals. He has created systems, and he has run systems. Today, he operates out between Calicut and Kannur, the entire belt. He's the king in that region. So he takes care of the entire cardiac armamentarium on that part of Kerala. We have Professor Libert also. We have who's with us. He's from. We just were having a chat with him. Dr. Gomes, welcome. And he's from Father Muller's College. He's assistant medical superintendent, and also he's a hospital administrator, and he's authored books. He has been faculty for National Board of Examination for hospital administration, has multiple papers and publications to his credit, and a lot of work on hands-on as well as in theoretical field in administration. So it will be a very exciting discussion. We'll be both discussing regarding the administrative nuances as well as the on the ground clinical things. And we also have our own colleague of Practo, Dr. Sudip Roy, who has recently come back from Republic of Congo. He was working there as a senior consultant in microbiology and infection control. He's also one of my old colleagues in one of the previous organization where we worked together. He's an infection control champion, an infection control person, and he's also been the director of lab services. Currently, he's the senior director for the teleconsult vertical as well as the pharmacy and the lab services for Practo. And welcome, Sudip, and it's nice to have you back in India. And so we are all here. So I think without wasting much of time, I'll just hand over the podium to Dr. Abel to kind of give his thoughts on today's topic, which is again patient quality and safety, COVID and thereafter. It's all yours, Dr. Abel. And welcome everyone on the platform today, guests and all my CMSs and the entire team of Practo.
Thank you, Dr. Abhijit, for the introduction. So let me just share the screen. So before beginning my presentation, let me just give you the basis of how I'm going to take today's presentation. So initially, I'll be talking to you about on the basics of patient safety. Then I will talk about dimensions of patient safety. Then I will talk about, since the World Health Organization declared this year as the year of medication without harm, that is going to be the core theme. So throw some light on that. And finally, I would like to take you in Practo care surgeries, how proactively we have identified what are things which can threaten the patient safety and what are the precautions we have taken for that to ensure that we give a safe experience to both our patients as well as to our doctors and to the hospitals which we partner with. Okay, so let me start. So this is
Dr. Abel, sir, could you go in the presentation mode instead of like this?
Okay, just a minute. I'll do that. Is it okay now?
Yes, sir.
Okay. So what do we see from these two diagrams, right? So we can see a donkey being unable to drive the cart because excess weight has been loaded there. On the next side of the slide on the presentation, we can see a person, okay, using a saw to cut the wood by keeping another person as the table to do that, right? Very dangerous practices. And here we can see this happened some years back, which a hospital in Indonesia, the area which was prone for an earthquake. Okay, the hospital leadership team before constructing the hospital failed to identify and take adequate precautions to ensure that the building was earthquake safe. Okay, so when the earthquake came, so this is what the state of affairs there. And then you can see the hospital is understaffed. Just two junior doctors left to care for about 436 patients, very unsafe night shift. And the other side, you can see a nurse who's catering to about 20 patients in ICU. Okay, so with this thing, let us go forward. So let us see what World Health Organization tells what is patient safety. It defines patient safety as a prevention of errors and adverse events to patients associated with healthcare. So what does an effective patient safety management lead to? Decreased healthcare associated infection, zero tolerance to errors leading to no harm to patient as well as to the staff, strict adherence to patient safety practices which will act as a protective cover for the hospital, doctors against any litigations, safe design of hospitals protect the hospital from consequences of disasters, ultimately leading to good clinical outcomes and increased patient satisfaction. So dimensions of safety in healthcare. So there are three dimensions actually. Hazards due to unsafe care and treatment procedures, hazards due to unsafe facility, and hazards due to criminal activities. I will talk in detail about hazards due to unsafe care and treatment procedures and lightly touch upon the other two dimensions. So with coming to the human factors, non-standard abbreviations like using PCT for paracetamol, CST for continuous same treatment, writing the clinical documentation, which is not clear. It's there's a very poor legibility there. Then inadequate training and experience of healthcare providers. For example, going to a casualty department and seeing the medical officer who's not even trained on the emergency protocols, no expertise in BLS or advanced cardiac life support. Inadequate assessment of the patient's condition, just doing a superficial assessment and coming to a diagnosis and treatment plan, which is going to be unsafe for the patient. Hospital-acquired infections due to poor infection practices. Transfusion reactions due to improper grouping and cross-matching. Anaphylactic reactions because of failure to check for the history of allergy and testing of allergy. Then drugs, mainly look-alike drugs like atropine, adrenaline, sound alike. Malfunction of equipment like incubator burns, ventilator causing anoxia and death. Burns from physiotherapy equipment. Then patient factors, ignorance of patient about health matters. Many times it happens that when you do an assessment of a patient, the patient sometimes fails to give a proper medical history to the doctor, right? The doctors are not aware of the past medical history. The doctor is not aware about the drugs he or she is taking. Okay. For example, I came across a situation where a person was already on beta blocker and the patient couldn't comprehend that he or she is already on beta blocker. She couldn't tell the name of the drug. Unfortunately, the other doctor also gave another beta blocker. The patient went in for possible hypotension. He had a fall. Okay. So these sort of things has to be avoided. The non-cooperation from patients in undergoing treatment against wishes. Okay. Then high-risk procedures. Then systematic factors, inadequate communication with healthcare providers. See, mainly when we see communication, most of the time the visit notes are not being properly documented by the consultants, right? So when the next doctor comes, he or she is not aware what the previous in the previous shoot what the doctor has written or what has happened to the patient. Then lack of coordination between all the healthcare partners, doctors, nurses, paramedical staff, etc. Inadequate system for analysis of errors for improvement. For example, we collect a lot of indicators, and what do we do with these indicators? Do we actually analyze them for improvement? Then stiff cost-cutting measures. Sometimes many of the leaders, they are not even aware about the cost-cutting in healthcare, right? They are cutting on the manpower, cutting on critical equipments, okay? Cutting on safety items, okay? Then mismatch between facilities and types of care required. Inappropriate unhygienic diet leading to adverse effects. Hazards due to criminal activities, failure to warn patients to carefully keep their belongings, inadequate arrangement of security of vulnerable patients, like physical assault on patients by staff, visitors, damage to property, mass casualties due to terrorist activities, bomb explosion, hazard related to unsafe facility environment, lack of program of preventive maintenance or repair of buildings resulting into building collapse, like how we saw the previous picture of a hospital in Indonesia, uneven slippery floors, stairs and poor lighting, unsafe terraces and balconies, poorly maintained power supply distribution system, electrocution. For example, some of the government hospitals, okay, I still remember one of our known relatives, okay, who went into government hospital, that suddenly there was a power shutdown. He was on one ventilator. There was no backup. 10 minutes, there was no power supply and he passed away because of that. Okay. So failure to take adequate precautions for fire safety and other disasters. So what are the controls to be in place for hospital and patient safety? Incident reporting and analysis, identification of hazard, doing a hazard identification risk analysis and taking actions on that. Okay, then periodic mock drills, and preferably we can do a lot of mock drills in the night. Okay, because we always think that disasters would happen only in the morning, right? Then committee meetings like patient safety, safety and risk management, infection control, quality steering committee. See, these committee minutes are not for documentation purpose at all. Whatever action points have been discussed, okay, a target has to be given. Okay. And with along the responsible person, the next meeting, all these points have to be discussed to check whether they've been cleared or not. Then patient safety indicators and their monitoring, hand hygiene audits, surprise check in critical areas with regards to following safe practices, annual quality improvement and patient safety plan, proactive risk assessment. This is something very, very important. See, we are always reactive many of the times. If something happens, then we do a proper RC, we identify the root cause and ensure these things doesn't happen. But proactive risk assessment is very, very important. Before a disaster happens, before something can go wrong, you identify what can go wrong and see what are the existing controls you have and ensure that you prepare the proper mitigation plans and ensure that those are implemented. Okay. Then proper areas for all critical incidents. Okay. Because root cause analysis should not be seen as a fault finding exercise. It should be seen as a tool for learning to ensure that these things doesn't take place in future. Then implementation of the international patient safety goals. We have 6 goals. All of us know about it. So I'm not going into detail into that. Then what is an error? An error is the failure of planned actions to achieve the intended outcome. A deviation between what was actually done and what should have been done. Which patients are at most risk? Those undergoing surgeries, those with comorbid conditions, those in emergency room, those looked after by inexperienced doctors. Then older patients and other patients who are considered vulnerable. What are the common adverse events? This is not the complete list. The commonly occurring things I thought I'll just document and give you some thought on that. Delayed or misdiagnosis, medication errors, wrong site surgery, wrong patient surgery, equipment failure, patient identity, transfusion reactions, mislabeled specimen, patient faults, time delay errors, lab errors, radiology errors, procedural error, retention of foreign object following surgery, contamination of drugs, intravascular air embolism, failure to treat a neonatal hyperbilirubinemia, sexual and physical assault on the patient. 2 views of human error again. We have the person approach and system approach. In the person approach, the thing is the person himself or herself, for example, is not trained. Okay, poor motivation, carelessness. Okay, the fault is with the person, right? In system approach, the SOPs, the standard operating protocols or process what we follow in the clinic or a hospital, that itself, there is a lacuna in that. Okay. So this is, many of you might have seen this diagram previously also, the Swiss model of accident causation. Okay. So it identifies failures in systems. Okay. For example, leadership, poor leadership, which is who's involved in excessive cost cutting, equipment shortages, leading to poor staff motivation, divided or confused accountability, having poor compliance to policies. Okay. Not having trained manpower. Okay, not communicating things properly, not doing a proper assessment. Okay, wrong site marking, wrong procedure performed. Okay, fail to review allergies during the initial assessment can lead to a wrong site surgery, a medication error, fall, etc. That's the reason. See, many of us say, what are you asking us to document this safe surgery checklist? What is the need for it? Okay, once we optimize the patient, we take the patient to surgery and then go ahead with the surgery, right? So, for example, this safe surgery checklist help us to prevent wrong site, wrong patient, wrong injury. Okay, it has 3 components: sign in, time out, and sign out. Okay. Then source of system error, overall culture, because if the top leadership is not committed, the culture of the organization doesn't give importance to patient safety, then everything fails. Then education, training, and experience of doctors and nurses and other paramedical staff plays an important role. That's the reason we have to take adequately trained manpower. System design. Okay. Then resource availability, demand, supply, volume, like in that. Shift work schedule. Sometimes if you go to a hospital, we will say that the nurses are doing continuous shift for about 2 days. Okay. So these sort of things can lead to system error, leading to adverse events. So let us see what is the patient safety in Indian scenario. To fight the spread of health cancer infection with millions of patients each year worldwide, the Ministry of Health and Family Welfare launched a global patient safety challenge and signed a pledge to acknowledge India's commitment to address this problem. The first inaugural event was held on July 14, 2006 with the motto "Clean Care is Safer Care." Then recently we have the National Patient Safety Implementation Framework from 2018-2025 that has been developed by the Ministry of Health and Family Welfare, Government of India, which has outlined the existing challenges, and they've also given the documented suggestions for the implementation. Then the level of awareness, however, progressively increasing due to the recent quality movement like JCI, NABH accreditations. Then let us go in detail into medication errors. Okay, since the WHO has given us a theme, medication without harm, let us go in detail into medication errors now. Medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm, while the medication is in control of the healthcare professional, patient, and consumer. So medication without harm, 2022 theme of WHO. So according to a survey, an estimated 90,000 hospital deaths occur in USA every year from medical errors, out of which the most common error being the medication error, most alarming. The number exceeds the death on highways, deaths due to breast cancer, deaths due to AIDS each year. Okay. Medication errors can occur at any step of medication use. Medication errors occur in nearly 1 out of every 5 doses given to a patient in the hospital. It can be any one of the type: administration, okay, prescription, transcription, dispensing. So cause of medication is difficult to read the doctor's prescription, illegible handwriting, when nurses get distracted by other patients, co-workers, or events on the units, when nurses are tired and exhausted, when there's a confusion between two drugs with similar names, look alike, sound alike, or spell alike. Then cause of medication is again miscalculation of dose when wrong doses are prescribed, failure and indication of patient's record, adjustment of infusion device is incorrect or confused by different types of function. Then who is responsible for medication safety? We as healthcare, not only the doctors and nurses, including the patients, are responsible for ensuring medication safety. So medicines are used to treat diseases, manage condition, relieve symptoms. Medicines are generally safe and used as prescribed or as directed on the label, but there are risks in taking any medicine. Adverse drug events or harms resulting from the use of medication include allergic reactions, side effects, over medication, medication errors. Adverse drug events are a serious public health problem, but many are preventable. That's the good news. The medication safety program focuses on prevention of adverse medication events by supporting clinicians, empowering patients to achieve best practice in medication management through implementation of proven and sustainable strategies. This aims to ensure that clinicians can safely prescribe, pharmacists can carefully dispense, and nurses can appropriately administer medication to monitor medication use. It is also intended to ensure consumers are informed about the medicines and understand the individual medicine needs and risks. So this is a strategic framework which WHO has put forward for this year. So the 4 domains of challenge include patients and public, healthcare professionals, medicines, systems, and practices of medication. So prescription errors, as we know: omission error, suppression of a drug previously used, commission error, addition of a drug not previously used, dosing error, incorrect use, frequency error, incorrect dose frequency, pharmaceutical form error, incorrect pharmaceutical form, duplication error, 2 drugs of the same class are prescribed. For example, I told you this example of 2 beta blockers being used on a patient simultaneously. Then transcription error, this type of error occurs when the prescribed drugs are intended through a system or manual slip, when copying drugs from old drug to new drug chart, or during in-house transfer of patients. This type of error can be reduced if the drug chart is written with extra care. For example, if dexamethasone 4 mg is written as 40 mg, or if tablet clopilate is misread as clopilate A, and it can cause serious side effects. Just to give you some examples on this. Like this, there are many. Administration error, this error happens while consuming the drug when it's administered by nurses or patient. It can happen if the drug chart or prescribed drug is not checked properly. The drug dose, frequency, duration can go wrong in this type of error. Administration error is the only error which is a sentinel error. We know what is sentinel event, right? So there cannot be a near miss in administration error, as in all other type of errors will be overlooked by 2 or 3 persons, such as a duty medical officer who checks the prescription, clinical pharmacist checks for appropriateness, nurses check the drug for indenting. So in this process, the error can be identified and stopped before reaching the patient. But in the administration of drug happens only with 1 person. So utmost care should be taken while administering the drug. Dispensing error, this can happen while dispensing or compounding the drug for the patient. It can happen due to wrongly reading the prescription, improper labeling, misplacing the drug, or careless compounding or dispensing. This can be avoided by double checking the prescription and the drug before dispensing. This error happens commonly with lookalike, sound-alike drugs or with verbal orders of drugs. Then finally, we come to monitoring error, like measuring and monitoring a patient's clinical lab values critical for diagnosing problems, gauging effectiveness of treatment, and selecting appropriate dose of many drugs. Breakdowns can occur when necessary monitoring of lab values is not ordered or performed, or when abnormal levels occur and action is not taken by healthcare practitioners. Right? It's a very important point, monitoring error. So like how we have the 5 moments of hand hygiene, now WHO is doing the 5 moments of medication safety, like starting a medication. What is the name of this medication, what it is for, what are the risks and possible side effects? Taking my medication, what should I take? Why? When should I take this medication? How much should I take each time? What should I do if I have side effects? Adding a medication, do I really need any other medication? Can this medication interact with any other medication doctor interactions? Reviewing a medication, how long should I take each medication? Am I taking any medications I no longer need? This happens many times, right? when our patient comes to clinic, we tend to realize that some of the drugs might have been given by the clinician for that moment of time, but the patient is still taking that without any rationale, right? Stopping my medication. When should I stop each medication? If I have to stop any medication due to an unwanted effect, where should I report this? So how can you minimize the opportunity for medication error? Choosing the correct patient, ask the patient for his or her identification, read the patient wristband and include the information given on it, double checks, complete the checks independently, double check the critical steps in the process, be specific as to what is to be checked and who is responsible, complete the checks even if the person who completed the first check is the expert, very important. Then just to give you some introduction about LASA drugs, hydroxyzillin, hydrochloride and hydrochloride, okay. One is antihistamine and another one is used to lower the blood pressure, okay. So these are sound alike. Then patient safety initiatives and Practo care surgeries. I'm coming to the final one. So first thing what we do is credentialing of doctors by the qualification, ensuring they carry adequate experience in the procedures patients seek as per the NMC, IMC guidelines. Okay. So far, we don't empanel all the doctors. We have a credentialing process where we have put how many years of experience required, etc. Everything. And once the credentialing done, then our city medical superintendent does the privileging part. Then we conduct a thorough evaluation of clinics and hospitals before empaneling them with regards to statute and mandatory compliances. Carry out an on-site assessment of the infrastructure, much more robust than the other assessments. Clinical outcomes of clinics and hospitals. Then we have a 3-stage medical approval, which I'll be talking about in the next few slides. Then prioritizing patient safety and quality of care in all situations. All surgeries take place only after thorough physical examination by both the surgeons and the anesthetist. Adherence to strict guidelines for consent and documentation for surgery, anesthesia and all procedures associated to the care of the patient. Compliance with the latest clinical guidelines and evidence-based medical practices and patient care pathways. That's the reason we daily have a medical team meeting in the morning and evening where we discuss all these things. Okay, the latest techniques, all those things are being discussed. Okay, and which is good for the patient is again put a discussion. And ensure correct medication management practice. Ensure there is no misuse of antimicrobials and minimize unnecessary transfusion of blood products. Zero tolerance policy towards any negligence arising out of patient care. Then steps to ensure quality of care. We have a medical operations manual design, which is called the Practo way. Okay, this was the first step to ensure patient safety. Okay, much before we started this. Okay, much before the rolling of the Practo care surgeries happened officially, the Practo way document was put in place. Then we have a customized comprehensive patient assessment format, strict SOP and quality audits for all patient encounters. We have OPD scorecard, surgeon's objective scorecard, hospital scorecard, where the data is being continuously monitored and discussed. Okay. And 3 stages of medical approvals, which I talked to you earlier. So we have the pre-hospital where the patient identifiers, name and UHD, name and type of surgery, anesthesia type, equipment and consumable required, surgeon details. The surgeon has been credentialed and privileged. Details of the hospital has been approved by the medical team. So this is done by the city medical superintendents and the assistant medical superintendents. Then again, on the day of surgery, again a counter check is done by the city medical superintendent and assistant medical superintendent with regards to pre-op investigations, whether the pack is done or not. Okay, whether the surgery and anesthesia consent has been complied. Any other clearance like cardiac clearance which is required for the patient. Then before discharge, again our medical team does a check on the final diagnosis, details of procedure performed at the hospital, condition of discharge, whether the patient hemodynamically stable at time of discharge. Okay, medications are clearly written, no abbreviations, very, very important. Diet and follow-up instruction, when and how to obtain urgent care, there's a warning signs. Okay, when to seek emergency care once the patient gets discharged. Check on post-surgery counseling by the surgeon. Then SOPs and quality audits at PCS, we have structure, process, and outcome, because a very good structure and effective process can lead to a good clinical outcome. We believe in that. So we have developed a checklist, which before we onboard any hospital or clinic, we have how a consultation room should be, how the pre-op area should be, whether the adequate equipment is there, whether adequate staffing, trained manpower is there, whether the OT recovery room conforms to the evidence-based guidelines, whether the CZ sterilization equipment is there, whether the chemical, biological indicators, those things are being checked, validation tests are being done, multi-para monitors are there, whether they have preventive maintenance calibration checks done. Then does the hospital have a critical care backup with all life-saving equipments? Then processes like initial assessment, preoperative workup, consent, PAC and immediate PAC. safe surgery checklist, transfer from recovery room, whether it's evidence-based criteria like how we use the Audits criteria, CCTV discharge, incident reporting protocol. This we always check whether the hospital has an incident reporting protocol or not, because we want to ensure that the hospital team also learns from each and every incident, whether the staff attendant behaves in ACLS, biomedical waste disposal, etc. So like that, we have a lot of protocols. Then leading to desired outcome like what is the incidence of post-operative complication is being discussed, what is the re-exploration rate, post-operative infection rate, adverse events during anesthesia, return to emergency in 72 hours, and what is the patient feedback. All these things are being discussed in the medical team meetings and the patient experience meetings. And finally, let us come to what are the 7 steps to patient safety. Lead and support your staff, very important. Foster a culture of safety, because not in talking about this in the patient day itself, as I told you, in PCS, we started this much before. Okay, so that's the reason briefly I told you. Of course, Dr. Abhijit will be talking to you about this in detail. So briefly I told you what we do proactively, we assessed what are things can go wrong. We have put a lot of SOPs in place to prevent any adverse events. And being a digital healthcare, you know, we have to be even more extra careful. Then involve patients and the public, implement solutions to reduce or avoid harm, learn and share safety solutions, integrate your safety management activity. So, thank you.
Dr. Abel, thank you so much for taking us through a full walkthrough from end to end, quality systems and what we kind of do in Practo. Thank you once again. Let's start the discussion. I would like to ask first, see, whatever we do in the hospital, it cannot happen if we don't have support of the administration, whether it is a government hospital or whether it is a corporate hospital or even a small nursing home. Without the proper administrative backup, we cannot actually function. So, Dr. Gomes, I'd like to ask you, as an Abel administrator and you are handling large unit. During COVID, we have had a lot of demand and supply, capacity crunch. We also had also to ensure that that we could deliver a kind of care. So the nurse-patient ratio, the RMO patient ratio, all this got completely turned upside down. And to add fuel to the fire, I would say, rather to cause more inconvenience to the hospital administrators, what happened was that during February 2022, the government of India also started having a list to penalize hospitals, where the hospitals could not hit certain quality benchmarks and deliver adequately upon the patient infection data. With that, we had to really make a lot of changes, which we had done rapidly during the pandemic situations in the hospital. And then also post-COVID, when I remember myself handling a 100-bedded ICU. We had 9 ICUs when I was the director and head of critical care in AMRI Hospital, Calcutta, which Sudip knows well. So that time I remember handling 40 patients a day myself from morning till evening. Severe crunch of RMOs and sisters and ventilators and all kinds of things, as usual. And then we had to really go up on the manpower, do some rapid changes over there. And then after the pandemic got over, we were faced with this thing, what to do now, because some of them did require to be reformalized, whether we should continue with the existing policy, whether we should have changed the policy now. So how did you deal with this entire upsurge, you can say, of resources that we put in the healthcare system during the COVID? And I'm talking in terms of certain areas, may not have been so much in the OT areas. I'll come to the OT areas when I come to Dr. Anand and Dr. Shyam. But if you see the ICUs and the emergencies and some of the areas, even the lab services people were crying. First time I'm seeing pathologists, microbiologists literally struggling and calling me up, boss, I can't handle so many samples. I can't work whole night. Sudip will also tell you that. So the thing is, how did you handle this crunch? And what was the transition like from the COVID to the post-COVID? Any changes you made in strategy in terms of your administration? Dr. Gomes? Is Dr. Gomes there?
Sir, I can see him in the number of participants, but he's not responding on the chat.
Okay.
Hi. Yeah, he's here.
Yeah, Dr. Gomes is there. You are on mute, Dr. Gomes.
Yeah. I was trying to connect. There was a slight delay.
Yes.
Could you hear me? What I wanted to understand.
Yes, I heard on the occasion of the World Safety Day, the topic that we are discussing now. I hope I'm audible.
Yes.
Yeah, this has been one of the very important aspects for us hospital administrators. We have had some nightmarish incidents at the table, post-operation, or during the surgery. Despite the best of the protocols and systems, sometimes things go wrong.
No, can you hear me?
Yes, I can hear you.
Yeah, so I was trying to understand that during the COVID, we did a lot of capacity enhancement, like we got a lot of ventilators. We had to put in additional staff in many of the ICU areas. We had to really revamp a lot of things and do a lot of rapid, changes in our protocols in the hospitals. But as the COVID went away, most of those things are slowly coming back to normal, and there is a lot of underutilization of a lot of things. So is there any kind of guidelines that you have formulated of what to do, and on how did you manage with this transition or the changes, or many of the things which you were doing that time, did you formalize those things or to suit the existing QI targets, or would you still like to continue in the same way? What did you do with and how are you using that resources, like what we had revamped during the pandemic compared to it for today? Like how are you kind of managing that entire thing? Because that time even the entire resource utilization was very topsy-turvy. So we just wanted to understand from the administrative perspective.
We did a lot of training, and we tried to put in systems in place, but a lot of things have become now not necessary. Some of the equipment that were received were found to be faulty also. In a hurry, of course, these things we can't openly sometimes share, but for just benefit of the panel and the participants here, we did a lot of things in enthusiasm, and we were very keen to implement things, yes. But a lot of things were faulty and we were rushing. Okay. We have, India is not bad. We have a very good capacity, building facilities are available, and we are very good learners from our mistakes. Right. But I wouldn't say at many places things are the same.
You are right, actually. I remember we were very much short of ventilators. Initially, in my around 400 bedded capacity, I could only get 40 ventilators to ventilate patients. So I had to depend on a lot of ventilators which came from Government of India, and then we had to really understand the software and the touchscreen interface, and some of them may not work that well. So all those things were there. And the fast training and the rapidity, I had to, even I remember training people, those who are fresh out of nursing colleges, and allocating patients with prone ventilation with very stiff lungs to them to kind of handle those kind of situations. But then, yeah, but one thing which helped us is what a person could have learned in 5 years. We learned in maybe few weeks or a few months. Yes. That is my personal view. Because the number of patients I have ventilated prone in those 8 months of Delta phase of COVID, and the number of patients I have put on ECMO. It was a learning curve which a person might require ages and years to learn. So it was a very fast tracking of our learning process through a very difficult window period. But yes, those who had faced those war-like situations definitely came out to be better equipped and better trained to handle more complex situations maybe today, if you see, because there's a lot of learning which went in, So yeah, many of those protocols we have also kept on continuing after the COVID. Some of them with the newer guidelines we had to phase off. When we come to the infection control now, with Dr. Sudip, we are there. See what as per the CDC data, present data, they say that during COVID, we had seen a lot of healthcare quality gap, which happened, which included, of course, the substance abuse, hospital-acquired infection, HAI, VAEs, COTIs, and increased rate of MRSA in the West, and of course, the gram-negative sepsis in the Eastern region, what we see, and a lot of fungemias, okay. And then post-COVID, we saw a lot of swine flus also. There were other kind of viral infections which came in. And they had also an extended effect and caused post-COVID. So as an infection control or as a microbiologist heading labs and services, what are the challenges you faced when we were taking a transition from the COVID into a post-COVID era? Can you just tell us a little bit about it? Dr. Sudip Roy.
Yeah, I think I am audible.
Yes,
so,
yes.
What happened with during the COVID? Okay, so whenever we are basically defining a process anywhere, be it operation theater, be it in laboratory or anywhere, okay, we expect some kind of variables, okay, some wanted or some kind of expected variables that we find it over there. So accordingly, we basically change our process and keep our, say, entire risk management and everything over there. But during COVID, there are so many of variables that has come up that we didn't expect. Okay, so I still do remember that one of Bill Gates saying that we are not at all ready for any kind of epidemics. Okay, so that during the COVID time, that was basically is one of the major problems. So once this, the entire process in a hospital and the patient influx has increased, okay, so what happened initially was that resources were getting tired, exhausted, okay, so it became very difficult for us to actually maintain most of the protocols, okay, because of, see, outside hospital, suddenly there is an increase into the follow-up of the say infection control protocols like wearing the mask, hand hygiene. Okay, if I would have gone into the market and saying the people that okay, you have to use that one, people may not have used that one. Okay, but in the hospital, it became very difficult to maintain. So there is a very contrasting scenario in the hospital itself. So what we try to do initially for both the aspects that we initially try to put up more manpower. Okay, so trained manpower. The training we started almost thrice in a day to get all those people get into these things. That what could be their safety measures from the infection control point of view, and what could be the patient safety measures from the infection control point of view. Okay. And another issue that has come up that when I basically measure the problem, okay, the data collection, the collection system is not up to there. Okay, so we were not understanding that whether the patient was having now some patient with the COVID has gone into a bad shape. Okay, and whether this is entirely because of the hospital acquired infection or whether this is because of the COVID impact or some of the things. Okay. From the laboratory point of view, the initial pressure on us was to get into the diagnostics of the COVID. Okay. So I have got a, say, 8-member team initially for the molecular lab. Okay. And within a fortnight, I increased it to a 40-member team, basically. And thanks to the thing that there are a lot of MSc people who have come up and who wanted to walk into this COVID scenario, not fearing because they have never walked earlier into a hospital scenario. Okay. So there are a lot of other people from the healthcare personnel who has actually come up at that point of time. And that helped us a little bit onto that thing. Now, post-COVID, when the transition is happening, okay, now what is happening that we are slowly getting down into the normal kind of scenarios, and from surgical point of view, operative point of view. So there was an issue that whether during the COVID, whether we should do the surgeries or not. Okay, so that was a major debate at that point of time. So initially, then what we decided that we are going to go for the emergency surgeries, elective surgeries can wait. And also people are not coming for the elective surgeries at that point of time. But for the emergency surgeries, what kind of, personal protective equipments, what kind of protocols, because everybody was getting so much anxious about the points, starting from the surgeons, OT nurse, and everybody was there. Okay. So ultimately we handled that one, but post-COVID, what is happening, it is coming and landing into that scenario. Okay. Now, see, the issue of the swine flu, it was there earlier also. Okay. I'm not going to say that it is coming with the COVID at this point of time. Okay. Because with the periodicity, it is supposed to come, it is coming at this point of time. And it is merging with the tail of the COVID. So we are getting basically both kind of patients right at this moment. Now, one point is that, say, from the viral disease point of view, okay, so there are a lot of things that we had to change, okay, because, say, for example, now, one example I'm going to provide you for the laparoscopic surgeries, okay. So now when you, say, distend the abdomen with certain kind of gas and other things, okay. So there was a question that was coming up at that point of time, that since it is a bit of droplet or airborne or something like that, so any virus which is having a droplet or airborne capacity, whether they can spread into the operative theater environment, particularly infecting the staffs over there. Okay, so those issues are coming up. So people have started thinking it from a new angle, and obviously newer kind of studies are coming up, and it is getting clear to us so far that, okay, fine. And from the swine flu point of view, the treatment point of view, we have got something that with that we can treat. But for the COVID, obviously, we didn't have much of the options over there, except for the preventive measures. But the active treatment, I'll say, is definitely. And when we are saying about, say, another new point that during the COVID that we have found out is that initially what happened that we were looking for the ventilator associated issues and other things, infections over there. Okay. Now, during the COVID, this ECMO has come up. Okay. And we need to basically formulate that what are the safety protocols for the ECMO is going to be, because the number of patients on ECMO and other things, those things are coming up. Okay. So that we also did. And we also basically learned a lot of things at that point of time regarding the ECMO, because we didn't have much experience with the numbers with that ECMO at that point of time.
Thank you, Dr. Sudip. A lot of insights into challenges of lab and the microbiology and infection control. I remember Dr. Anand, sir, thing is, I remember I was working at that point in time in the early days of COVID with one surgeon, a few surgeons in Asta. So they used to come up wearing this full helmet with a connection, to the exterior, and N99 mask and all of that. And people were very, very scared. And of course, RT-PCR, rapid antigen tests, whatever possible to kind of, not to take any elective surgeries. And, COVID protocols came in general surgery and all of that. Yes. So do you, what are the measures you take now, since the COVID has almost come into a different kind of viremia in terms of its virulence and in terms of its spread. So if you do, say, a laparoscopic surgery where you have to insufflate an abdomen with CO2, and of course, there's a lot of aerosols in the theater. So do you still do an RT-PCR for all your patients, or how do you screen a patient, and what are the precautions you take for safety purpose for yourself and your staff around, for any staff, whether it is and just to rule out if a patient is in COVID or not in COVID, or if a patient is, say, after how many days of symptomatic COVID, what do you do? What's your practice guidelines now? Dr. Anand, we can't hear you. You have to unmute yourself, sir.
Hello. Are you able to hear me?
Yes,
Hello.
yes, we can hear you.
So we just take the history and then see that there is no person in their house or he is suffering from this COVID for some a week or so. And we do the test also. And in addition to that, to safeguard our staff. And more than that, we don't take much now. Now, since it is everywhere it is present, it has become endemic in many areas. We take only this measures to see that it is not among us professionals, especially. Nothing much we do.
Do you still wear the N95 mask in the theater, or you wear wearing the normal surgical mask?
No, we wear N95 mask also. Some prefer to wear.
Okay,
Still, the fear is there among the professionals, they wear that.
Okay, N95, so rather I will be wearing in case I have to intubate a patient, because I'm very close to the airway. But yeah, for a surgeon who's away from the airway, I don't know whether, yeah, it is okay to wear that. Yeah.
It's only as a safety, because once it comes, we can't talk to the staff about our inefficiency, so we just may ask them to wear if they wish to wear it.
Okay.
But so far, no such incidents in our place.
Okay. Okay. Doctor, do you get patients for surgeries, or do you refrain from surgeries on patients who come with, say, post-viral fatigue, or what's your duration of waiting? Because generally many patients, they recover, because we have this challenge in our Practo care surgery. Of course, I have already given a guideline based on the CDC, a period of wait for around 4 weeks for asymptomatic patients, and a period of around 3 to 4 weeks. And anybody who has symptomatic patients for around, or hospitalized patient for a duration of 6 weeks. Supposing somebody would have had a symptomatic COVID, but not admitted to hospital, had a saturation of 94 in the house and recovered. So how long will you wait from the abatement of symptoms till your surgery? Is there anything like that you observe?
As you said, about 4 to 6 weeks I wait. We tell them to wait till 4 to 6 unless it's an emergency.
Coming to Dr. Shyam, I know.
Emergency.
Yeah, okay. Hello, thank you, sir. Coming to Dr. Shyam, I know cardiac surgery is a 24/7 kind of work, and you operate as well as you have to take care of the post-operative ICU. Did you use a lot of any kind of let's say video assisted monitoring in your ICU during COVID to reduce because see, manpower is fixed and you have to protect your staff. You can't have all the staff all the time in the ICU. So during COVID, and of course, hospital administrators, they don't give too many staff to the cardiac surgery unit as such, unless and until we are a standalone unit like NH. So the thing is, in centers like, did you do a remote monitoring also for your post-operative patient on basis of you are mute, Dr. Shyam. Yeah.
Can you hear me now?
Yeah, I can hear. We can hear.
Yeah, no. So I did not do any remote monitoring. Basically, because what I did was nowadays it's very difficult to get a cardiac trained nurse. That is
Yes.
the main challenge actually, because all the nurses are leaving. They're trying to do OET and ILTS and whatever. They're trying to leave as soon as possible. It's very difficult to get a trained cardiac nurse. So what we did was at the time of COVID, we used to cut down on the cases because we had to take care of ourselves, our staff, as well as the patient. So we could operate only whatever we could with the available resources. So, for example, if one or two of our ICU staff had COVID, we would actually reduce the number of cases so that the others, otherwise the others would have to bear the brunt of the ICU duty, and then they would have also left us something. So we had to reduce the number of cases. That is the way we used to do. But to add to whatever we are talking right now about patient safety, for me as a cardiac surgeon, patient safety starts from the time the patient comes to my outpatient chamber. So if the patient comes for surgery, I would weigh always the risk and benefit, whether he would really benefit from the surgery or not. Because sometimes I would be able to do the surgery, but would the patient really benefit from it? Because patient may not be fit for general anesthesia. So if in such a case, if I jump and do a CPG, we may not be able to, even get the patient off the ventilator. So it is very important to really, assess the patient, whether the patient is a fit candidate for surgery or not, whether there are any other options available for him, what is the best option available. That is the first thing. The second thing, which I really feel is very important, is communication. The communication, because the patient and the relative should know what exactly we are going to do, what is the nature of the disease, and what are we trying to do. So that is a very important aspect, because we need to make sure that they really understand the surgery as well as the benefit of the surgery. Secondly, one more thing, especially which is relevant in cardiac surgery, is whenever I operate on cases, I usually have a small talk with my anesthetist as to what I'm going to do, so that there's a sync always with the anesthetist. This is a very important member for discussion on how to go about it. What is the plan? See, as you know, cardiac surgery can sometimes give a lot of surprises on table. So we need to be prepared for it. And I usually also have a talk with my team members, the perfusionists, the scrub nurse, as well as the cardiac anesthesia team, the technicians, and all those people, so that we have a really understanding as to what we are going to do with the patient. And lastly, in the theater, we always follow the timeout procedure, so that the usual things which Dr. Abel had mentioned, what the surgery performed, what are the team, who are the team members, what is is there any deviation from the normal routine, what we are going to do, and what is the anticipated blood loss, so that the technicians and the anesthesia team have a heads up to whatever, in case something goes wrong, they are prepared to do the thing. So these are some of the aspects which I thought is important as far as patient safety is concerned.
Yeah, thank you, Dr. Shyam. Actually, it's very important to adopt a comprehensive approach. Really, that it's generally a cardiac surgery or any surgery for that matter. Very important to understand whether we should really be operating on the patient, whether the physiology permits us to operate the patient, whether he is in a hypercoagulable state, whether he has got existing lung fibrosis or a stiff lung. If you intubate him, can you extubate him? And so many other things, like whether the physiology permits us to really take that case and go forward. So it is so important to understand that and have a comprehensive approach. And I know that you have a very, very good team approach to the entire problem all the time, because I have also worked with you in the previous setting. And yeah, and that is so important. And especially the WHO surgical safety checklist, what we saw many of the centers, they really adopted that very strictly. That added on a additional safety guard for those patients who otherwise in many centers, they don't do it. But it added on to the safety of surgical care, certainly. And in Practo also, we have made it mandatory that all our patients, those who go for surgery, one of the checkpoints of surgery is the WHO surgical safety checklist, which we have to see, and then only we permit the knife to skin. So if a center does not have it, we do not onboard it also. We do a lot of random checking. So yeah, that is very important. Dr. Sudip, one question I would like to ask you. I think in a lack of time, we have to also close in. What do you suggest, Dr. Sudip, going forward because we have surgeons here on the call with us. So we wanted to understand from you, what should we check? Should we keep on checking RT-PCR or a rapid test? Or how should we take up an elective case? Of course, emergency case, we always take it up as an emergency. But for an elective case, what should be the guideline as per the ICMR? I know that the recent guidelines of CDC last month and the ICMR also states that we should not be testing a patient unless and until the patient is symptomatic. And thereafter, even after testing, you don't really need to do anything. If a patient is symptomatic, then only you have to consider all the other factors. Otherwise, just go ahead with a surgery without testing. So, what are your take on that, Dr. Sudip, on this?
Okay, so there is what is going to happen. Like the coronavirus is basically say RNA virus, same like that of the influenza. Okay, so now what is happening? Like we are having the dates and other things. We are having the vaccine to some extent, protection and everything. But again, it is going to come after some years, okay, in a new variant, new format, new strain, or something like that. Okay. Now, regarding the question that you have asked, that whether we should go ahead with the thing, there are some of the guidelines which are very clear-cut, like say whether we should do the testing or not, and if a person is having a corona or had a corona infection, then when we should do the surgery. Okay, usually what you have said that 4 to 6 weeks after the thing, and if everything is fine, then only we are going to take those things as elective surgeries and other things. Okay. Now, regarding the point that whether we should test preoperatively or not. Okay. Now, here comes a catch that corona has got a vaccination. Till now, we do not have any vaccine titer study that can say that you are protected with the corona. Okay, so that is one of the point that may come in future, that if you are having this much of the titer with the vaccine, then probably maybe you do not have to go for the testing. And regarding the other points, that whatever be the government has given, that considering the asymptomatic people or say maybe very mildly symptomatic people, if you can delay it for some time, you can delay it. Okay. But yes, obviously, with the people with having a bad kind of a corona disease, okay, obviously has to wait for an elective surgery much later onto that thing. Okay, so the ultimate policy for the testing is that, say in India, if you are seeing that okay, the person is vaccinated, you may not go for not having any symptoms. You may not go for the testing. You can go right away with the say. The surgeries, okay, and during the surgeries you keep on having your practice of your own safety as well as patient safety, whatever be the guidelines are there. Say suppose if there are say 25-30 points in the checklist, you maintain it very strictly so that both the side can remain safe. But in my experience, what I have seen in Africa, they have refused to have those vaccinations. Okay. Most of these African people, they are not very keen on having the vaccination. Hardly 2% people have taken the vaccine. Okay. Not even the country's president have taken the vaccine. Okay. So there the scenario is different. Okay. Here, what they have to do, they are basically still now checking preoperatively with the testing and everything. Okay. Because what I have seen among that particular African black population, there are a lot of asymptomatic cases. Okay, they are roaming around with everything, but coming as a positive when we are doing the testing over there. Okay, so there the policy is a little bit different. Obviously, in India, we can vouch onto that vaccination, and we can go ahead with not having the testing, and just pre-operative.
Dr. Shyam, you wanted to ask something?
No, actually, what I would like to say is what we are seeing is now we are actually seeing a milder form of COVID, whatever COVID infections, and it is entirely different from the initial Delta severity what we used to see. So now what we are doing is we are not doing RT-PCR testing because many times, even if they're asymptomatic and if they had COVID infection recently, they would be having this RT-PCR positive. So what we are now doing is the antigen testing. We just do rapid antigen testing. And if it comes out positive and if the patient is symptomatic, then we defer the surgery. And how long we defer the surgery? If the patient is asymptomatic, after 1 week, we just take the case and do the surgery. And we have seen that it has not really altered the course at all. Because we have operated many patients who were COVID positive, who had very mild symptoms, but they were COVID positive and subsequently became rapid antigen test negative. We have taken the patients for surgery and they have behaved the same as the non-COVID patients. So I don't know, this is my experience. I don't know whether it is the right one or not, but currently we are just doing rapid antigen testing. If it is positive, we defer the patient. If it is negative, we just take the case. So this is what we have been following.
Antigen will stay in the blood for around 7 to 10 days. So if he's in an active viremia, it will rule out the possibility and you should not go for it. But after 7 to 10 days, anyway, the antibody will spike up. So that, and we do not do actually antibody testing to really understand whether the patient has had COVID or not. So we don't do that. So anyway, it will become negative. The RT-PCR will keep on coming positive for weeks after the infection because of the shedding of the virus. Even the dead virus will be picked up, and that is what you will get. Dr. Gomes, you are there still? Dr. Gomes?
Yes, I'm there.
Yeah. Did your hospital adopt something like a clinical decision support system, CDSS, in their in-hospital software? Because a lot of artificial intelligence also was adopted during this COVID phase for diagnosis to aid the physicians in their OPD, IPD diagnosis, pop-ups like because of drug reaction. If the creatinine is high, whether we should come down on the dosage of some NSAIDs and things like that. So whether to alter the dose of antimicrobials and antibiotics. So there was a lot of artificial intelligence integration into the hospital software to prompt the patients and the physicians, prompt the physicians to take decision called the CDSS. Did you have anything like that in your
No, unfortunately, we could not adopt such a system. It was difficult, and since this is a teaching hospital, we had a weekly audit system, and we have not done it.
Okay, thank you. Dr. Anand. Dr. Anand, sir, you are there?
So he is here. I'll just ask him to unmute himself.
And ठीक है अगर है तो.
Dr. Anand, sir, are you here?
I think you may not be able to hear us because of bandwidth.
Yeah, I think so.
Yeah. So the thing is, what we saw in COVID is one of the two things which is again become very. Just to wrap it up, that there's something called PVF, which is called post-viral fatigue, and PPS, which is persistent physical symptoms like chronic fatigue syndrome and myalgic encephalopathy and all that. So many of the patients who had, which is also a term called long COVID syndrome. So many of the patients, those who have recovered from COVID, forgetfulness, memory loss, persistent fatigue, psychosocial adjustments, all these things are are newer dimensions which are coming into the challenges when a patient comes also for surgery and also post-operative in the post-operative setting. Again, problems with coagulation, coagulopathy and parameters, patients on long-standing anticoagulants and all of that. So maybe we all have to adopt a new approach and not just take whatever we have been doing all this time before COVID. During COVID, we of course we avoided elective surgeries. We did emergency surgeries, but coming forward, there will be patients will be coming in with something called the post-viral fatigue and long COVID syndrome. And we also need to really watch out for this kind of phenomena, which are of course add on to the phenomena of or complexities of the surgery in itself in the days to come. So anyway, thank you everyone for your active participation, and thank you Dr. Abel again for a end-to-end kind of presentation. And thanks to all the panelists and all the doctors who participated. Dr. Nilesh, the last words goes to you. Vote of thanks to all of us, then we can wrap up.
Yeah, I would just like to thank everyone, but sir, I have one question of my own, if you would permit me to ask, sir.
One क्यों 10 पूछ लो.
Sir, एक ही बहुत है. Sir, I was wondering would there be a long-term change in surgical practice post-COVID? क्या कुछ नए practices आएंगे which would have a long-term effect after COVID? Would we change some practices in surgery?
See what happens with surgery. Let me just take it. What happens with surgery? We see a typical surgery is a noxious stimulus. Okay, it's a physiological stimulus which is given to the patient, and then the patient has to recover from it and return back to physiology. What we see with this coagulopathy, what we see with neurohormonal axis and all of that, central fatigue and all of that putting together, there are implications of delayed recovery. What we have eyeballed in Practo care surgery, because we have a huge data of 1,500 patients in a month. Almost we have gone through 15 to 20,000 cases in last 1 year. I don't know whether it is too early or to pronounce or to say or to even infer, because we don't have the data points to really come to a diagnosis like that. Whether patients, those who have recovered from not, so everybody has had COVID. That is for India. Mein, whoever has been living in some form or the other has had that COVID and has recovered also, including me, who has also had COVID twice and we have recovered. So now what happens is we don't know whether COVID in itself has a implication on recovery, because what patients is to recover in say 7 days time, suture removal, maybe 3 weeks time to completely recover. For cardiac surgery, maybe 3 to 4 weeks time, 6 weeks they can go back. Dr. Shyam can tell us better. But whether those who have had COVID, whether there is any implications of that COVID on a long-term recovery, if he undergoes an elective surgery like cardiac surgery or a lap chole or something else, I have no idea. I think we should have a recovery database across India to understand the phenomena. What you rightly pointed out is something very important. We really have not studied the long COVID syndrome and implications on recovery from any kind of surgery because of that. Really, I don't have any idea, because surgery itself is a nauseous stimuli, which puts the system into a different mode of inflammation, and then again it comes back. It was normal thing, but already COVID is a multi-system inflammatory disorder. Okay, so whether that in a long term has an implication on this, I don't have any idea. Maybe it's scope for research and maybe a big scope for observational study to go forward. Yeah.
Right, sir. Maybe we could do this study in our Practo care surgery patients, sir.
No, Dr. Sudip Roy karenge usko.
Absolutely. Thank you, Dr. Ashok, for spending time with us this afternoon on a Saturday. And I learned a few very good things from you. Thank you, Dr. Sudip. Thank you, Dr. Anand, sir, and Dr. Anil, sir, for spending time with us on a Saturday and giving us a precious time. And thanks to all the audience who've been watching us quite diligently, even till 20 minutes beyond the time. We still have many audience watching us. So thank you, everyone, and have a very good evening ahead.
Thank you, Dr. Gomes and Dr. Shyam, for joining us also.
Thank you. Bye-bye.